In Chapter 25, we are going to talk about poisoning and overdose emergencies. Some of these are intentional, but many are unintentional. In this chapter, we will cover poisonings and alcohol and substance abuse. So poisoning is any substance that can harm the body. And when we think about poisoning, we have to understand that some things we can take smaller amounts of, but when we exceed those safe amounts, it's also considered poisoning, even though it may be a legal or natural substance. The harm that it can cause, though, can be a medical emergency, and these patients need to be taken care of right away. The longer after the exposure, the more damage is going to be done. So some poisonings may be from medications that are prescribed to a patient, or maybe ones that aren't, petroleum products, cosmetics, exposures to pesticides or other chemicals, plants, and foods. When we think about how a poison is going to affect someone, we have to take some things into consideration. We think about the nature of the poison. We think about the concentration. Was there a large amount of it that the patient was exposed to, or just a little bit? What was the route of entry? Meaning, was it absorbed through the skin? Was it medication that they ingested, or something that they even injected? The patient's age, because the very young and the very old do not have the compensatory mechanisms to try to protect themselves as well. Weight, and their overall general health, like underlying medical conditions, cardiac problems, respiratory history. We want to look to see if there's any damage to the skin or the tissues that we can identify from contact with this substance. Suffocation can even occur depending on the chemical, and localized or systemic damage to the body systems. Remember, local is going to be in one specific area. Systemic means it's affecting the whole body or multiple areas within the body. We think about the route that the poison was gotten. So that could be through ingestion or being swallowed, like with some medications. It could be inhaled or breathed in, maybe a poisonous gas. Something that may be absorbed through unbroken skin, and some chemicals can do that as well. And what about injected, where it's actually inserted through the skin? One of the roles of an EMT is education, and prevention from injury or poisoning is going to be one of those topics that you could share. When we talk about poisonings, it's important to understand that smaller children tend to explore their environment and put things in their mouths. If something looks pretty, it must taste pretty. But when we think about those smaller kids, we can encourage childproofing of the home, which will prevent, hopefully, poisonings. Have a lock on the kitchen cabinet that contains the cleaners. Have medications put up and away so that they can't be gotten into by the smaller children. We can teach these things in schools, in community outreach programs, or wherever you're invited. This picture goes back to the idea of the routes of entry. So if you think about it, how did this get into the body? Was it absorbed, ingested, injected, or inhaled? When it comes to ingested poisons, when we talk about kids, we know that it was probably an accident. They probably didn't realize that this was a toxic substance, or they didn't even know what it was. Like laundry pods for a while were being deemed unsafe because smaller kids were getting a hold of them and eating them. Adults, on the other hand, we can see this accidental overdose or accidental ingestion of medications, but sometimes this is deliberate. So if we're arriving on scene, we've been told that we have a patient who has a potential exposure of something, it's really important that we know what that substance was. If we can take it with us, let's take it with us. So if it were a chemical in a bottle, that bottle may have the whole list of ingredients of what it contains, and that's going to be helpful in the ER when they contact poison control. We also want to know, when did this exposure occur? Was it an hour ago? Was it a day ago? Because the longer that the patient was exposed to it and the longer period of time afterwards that we get to them, the worse their outcome may be. So we've got to act quickly, and we want individuals to notify us right away should there be a potential exposure. Remember, I said concentration and amount is going to be important. So we need to know how much they ingested. A lot of times, if you're looking at prescription medication bottles, the bottles will tell you how many were in it, and it will tell you the date that it was filled. So if they take a blood pressure medication that they take once a day and it was just filled last week, we can anticipate that the majority of the pills should still be in the bottle. We want to understand over how long of a period of time did this ingestion occur. And what I mean by that is, did you take all 50 at once, or did you take 10 and an hour later decide to take 10 more? If this is a medication that was taken for the very first time, the patient may not only have a reaction to it, but they may be allergic to it. Many times when there is an ingestion of something or a poisoning, people have tried something at home to treat themselves. So it's important that we find out what those home remedies were. Some people may say they tried to make themselves throw up, or they drank a glass of milk. When we get these chemicals and these things that may have been ingested, sometimes the treatment can be on the label. Sometimes it's not. What's the patient's estimated weight? Well, we know that medication and things are metabolized through the body based off of weight. So someone who is larger is likely to need more of something in order to reach that poison threshold. And children will experience greater effects because they are so much smaller. So one pill for you may not be much, but one pill to a 2 or 3-year-old could kill them. Find out how the patient is feeling if they're able to answer you. Are they feeling nauseated? Have they vomited? Or maybe they're completely altered and they can't answer your questions, or they're unresponsive. Sometimes they will be complaining of abdominal pain. They may have had diarrhea prior to your arrival. You can sometimes see physical burns around the mouth, and sometimes you can smell that odor on their breath. Food poisoning can occur in the home or out and about at a restaurant. The health department tries to manage safety features within a restaurant to ensure that the food that they are handling and preparing is done correctly to prevent food poisoning. But if we have a potential food poisoning, this patient is likely to have nausea, vomiting, maybe some abdominal cramps and diarrhea, and sometimes they will even have a fever. The important thing here is making sure that the surfaces that the food is touching has been sanitized appropriately, and that the individual preparing the food is washing their hands before they begin to prepare, and sometimes in between touching the different foods. So activated charcoal is charcoal, and if you think about charcoal, it's now in your face washes and all of that stuff because it's kind of made to absorb and purify things. So we have this liquid that's called activated charcoal that you can assist the patient in drinking. Activated charcoal is black. It smells like charcoal. It's not very pleasant to look at, but it does absorb some of those substances that may have been ingested. It's not an antidote though. An antidote reverses the property of that poison. The activated charcoal simply binds to it so that it cannot be digested, or it reduces the amount that is actually digested by the body. It's important to know what the individual ingested because activated charcoal does not absorb everything. So some poisonings, we cannot use it. And if you're unsure, contact medical control because they'll be able to guide you in, do you follow through with activated charcoal administration or just transport to the hospital? So activated charcoal is a medication, so there are some reasons why we would not want to give it. Again, we need to know what they've ingested. So if they've ingested acids or alkalis, then we would not be able to use activated charcoal. If the individual has swallowed gasoline, again, activated charcoal cannot bind to that. It will be absorbed pretty quickly anyways. The patient cannot swallow, or if they have altered mental status, we are providing this activated charcoal through a cup and a straw. And if the patient is not able to protect their airway and swallow appropriately, then we don't want to be putting anything in their mouth. You may have heard of a substance called syrup of ipecac. It used to be used on ambulances. This medication causes the individual to vomit, and usually one dose of it and they're hurling all over the place, so whatever they've ingested is coming back up. But patients have the possibility of aspiration, and we know that that can cause some long-term issues. We also know that syrup of ipecac does not really get rid of everything. It only removes about 1/3 of the stomach's content. So there's still a lot of medication or substance that may be in the stomach getting absorbed. So activated charcoal is now the way that we go. Remember I said concentration of the substance is important to note. Well, if we have certain substances that have been consumed, dilution may be one of our options to try to reduce the absorption, or at least reduce the concentration. If we have an adult patient, we may be able to have them drink 1 or 2 glasses of water or milk. A child, a half to a full glass of water or milk. This will help to slow down the absorption, and the milk helps to soothe the stomach. It kind of creates a lining and will create that barrier to make the patient more comfortable. Frequently advised for patients who is determined by medical direction or do not need transport. Dilution is an option, but again, make sure that you are contacting medical control and you know the substance, because dilution is not appropriate for all ingestions. So we have this patient. How is our patient care going to go? Just like we've talked in the past. We've got to detect any life threats first and deal with them if they are issues with the ABCs. We move on to that secondary assessment, which includes our baseline set of vitals so that we can monitor for the patient's condition to worsen or improve. We need to consult medical control or medical direction or poison control. Many times the emergency department will contact poison control because they will be seeing the patient for a long period of time, and poison control will follow up with them for an extended period of time. But medical control can help us to identify if we need to use the activated charcoal or if we need to dilute. We want to transport the patient with the substance with any additional information on the substance that may be available. And we want to do our reassessment regularly to ensure that we are picking up on even subtle changes with the patient's condition. Antidotes, as I said, are things that are going to neutralize or correct a substance that has been taken. There are few genuine antidotes out there. The one that we talk about that you guys need to be familiar with is called naloxone or Narcan. Naloxone reverses the effect of narcotics, particularly the opiates. And what it does is it helps to regain some respiratory drive and maybe even improve the patient's level of consciousness. Acetaminophen is also known as Tylenol. This is a common overdose medication. Some patients use it because their headache is just so gosh darn bad. Other people take a ton of them trying to harm themselves. I want you to understand that there is a delay in the reaction from the body because it takes a while to digest that. So in 4 to 12 hours, the patient may have some loss of appetite or nausea and vomiting. But it's not until 1 or 2 days later the individual starts to have right upper quadrant pain and jaundice. The antidote really needs to be given within those first 12 hours to be effective, because by day 1, 2, when the patient's having these more severe symptoms, it's already affecting the liver, because acetaminophen is metabolized by the liver, and therefore that's where it's going to cause the most damage. When we have an acetaminophen overdose or poisoning, there may be other things that the individual took as well. So we have to suspect there might be other substances that they have ingested as well. So we want to look around for any evidence of that. Deal with the apparent threats to life first. Again, we're going to be managing airway, breathing, circulation, our secondary assessment, providing any treatments that have been directed from our medical control, and transporting the patient. So the next couple slides are in your textbook on page 701, just talking about how we're going to go through those steps with a patient who's had a potential poisoning. You can see here the EMT has their standard precautions. They have their gloves on and they're gathering information. Here our EMT is calling medical control, letting them know the medications that have been ingested, how much, and when it was taken. The EMT is providing the patient with some activated charcoal. So they have put it in a cup with a straw, and again, it's better if the patient can't see it. It's not very appetizing, but do note that the EMT has at least on eye protection, because sometimes activated charcoal can cause the patient to vomit. If we reach that point and the patient is vomiting, you should have emesis bags in the ambulance, and anything that comes out of the patient, any of that vomit, should go to the hospital for evaluation. Sometimes they're just looking to identify what medications may be in it from a pill capsule, or if we can identify the multiple substances that have been taken. Do have your suction ready, because if this patient has a difficult time maintaining their airway and their vomiting, we're going to need to clear that airway and assist them. So think about it. Look around. Do you see anything in your area right now that maybe is unsafe for a small child? Especially when we think about chemicals, cleaners, medications. Are there potential poisonings within 3 feet of the floor or behind any unlocked doors? Again, kitchen cabinets, bathroom cabinets tend to be a common place where we see these cleaning substances. Household cleaners can sometimes look like juice. They may smell pretty. And flavored children's medications may taste like candy, and they may like it so much that they want to just drink the whole bottle. What sense does a small child typically use to identify things, right? Especially the younger they are, they're going to explore with their mouth. Everything goes in their mouth. They don't necessarily smell it. But if they get a little bit older, this looks pretty, this smells good, and they try to eat it, that's when we may have a poisoning on our hands. There are some chemicals that can be inhaled that create a poison situation. Those include carbon monoxide, chlorine gas, ammonia, agriculture chemicals and pesticides, and carbon dioxide. Inhaled poisons create a scary situation because as EMTs, we do not have respirator apparatuses that allow us to go into an environment like the firemen do. Their SCBAs will protect them from exposure to carbon monoxide and those other poisonous gases in a fire. So we need to really be careful. Take your windshield survey, look at the scene, and decide if it's safe. We don't want to enter and then be overcome by that inhaled gas as well. Protective clothing and the self-contained breathing apparatus, or SCBA as I said, may be required for some of these calls. And if you are not trained or equipped, then you do not go in. You need to call those individuals who have the appropriate training. So again, we want to get a lot of information from the patient, especially if their condition is worsening and they go unconscious on us, we're not going to get any more questions answered. So let's find out exactly what substance this was and if we have a container or a bottle that it was in. When did the exposure actually occur? Over how long did the exposure occur? And when we're talking about inhalation poisonings, think about it as the person was in that environment for an hour or for 10 minutes. So again, the length of the exposure to that substance. What interventions has anyone taken? Did someone remove the patient from the area? Did they open a window to try to ventilate the area? And what effects is the patient actually experiencing? Have the patient tell you the way they feel. Remember, those are the symptoms. The signs are going to be the things that you see, and those are important as well. So carbon monoxide is a common one that we see, and we know that firefighters sometimes have carbon monoxide poisoning as well because of going into fires and being exposed in their work environment. But carbon monoxide is a colorless, odorless, tasteless gas. You don't know necessarily that you're being exposed to it until you begin to have symptoms. We understand that carbon monoxide comes from incomplete combustion, many times from furnaces or from running generators, the exhaust, or from improperly vented wood-burning stoves. A lot of times we see the death rates from carbon monoxide climb after there has been some type of natural disaster or power outage because of the individuals using generators in enclosed spaces with poor ventilation. Patients typically will begin to have symptoms, and in the beginning, they start off kind of vague. They may complain of a headache, and it's many times described as a squeezing band around their head. They may feel dizzy or may say they're lightheaded. But as the exposure continues, they may develop some difficulty breathing, nausea, you may see some cyanosis, and ultimately, if they continue to be exposed, it can cause neurologic deficits and an altered mental status or unconsciousness. CO monitors are carried by firefighters so that they can identify if there is carbon monoxide in the area. Many homes these days have carbon monoxide detectors in them as well to prevent potential poisoning of the individuals living in that home. Most carbon monoxide poisonings, if mild, will alleviate themselves pretty quickly. We just need to get the patient to a well-ventilated area where they're no longer being exposed to that carbon monoxide, and they'll start to feel better. However, if the patient has been there for a long time, if we're seeing substantial signs or symptoms with the patient, then we need to give them 100% oxygen, and we need to get them to the hospital quickly. It does take time for carbon monoxide to kind of what we call wash out of the bloodstream, because carbon monoxide binds to the hemoglobin molecule where the oxygen is supposed to attach. But with time, that carbon monoxide's bond is going to break, and then the oxygen can reattach and the patient will return to normal. Again, If the patient is not as severe, they should correct relatively quickly after being removed from the environment. But some patients need more aggressive treatment. So specifically for carbon monoxide poisoning, we want to make sure that we get the patient to a safe environment. We want to detect and treat immediately any life threats with those ABCs. Do your secondary assessment with your vital signs. And again, if we're suspicious for carbon monoxide, we can put some oxygen on them, and that will help the patient as well. We want to transport any containers, bottles, or labels. Obviously, we don't want to bring toxic substances onto the rig, but if we're using poison control, a label from that bottle is all we really need. And continue to reassess your patient as you transport to the hospital. When we talk about smoke inhalation, I want you to think there are a couple things that could be going on here. So if someone is breathing in smoke, they may have thermal burns because they may be close enough to the heat source that they're actually getting burns on their lips or inside their mouth. And we know that whatever is burning may create an irritant or some type of chemical release that may be poisonous as well. So substances can burn the skin, they can irritate the eyes, injure the airway, they create that runny nose, watery eyes kind of irritation, and it can progress to respiratory arrest or cardiac arrest if not managed properly. We've got to be careful with patients with smoke inhalation because they may begin to have difficulty breathing pretty quickly if the airway is burned and beginning to swell. They also may be coughing a lot. They may have a smoky or chemical smell to their breath. We will sometimes see some black or carbon residue around their mouth and nose, or you may see it in their sputum. And the individual may have some singed facial hairs. So if they have a beard or mustache or nasal hairs or their eyebrows may be missing or singed, look for these key signs to help us in our assessment and treating this patient. With smoke inhalation patients, we need to make sure that the area is safe and we want the patient to come to that safe area. Here we're going to do our assessment of the patient, primary assessment, and move on to the secondary, but make sure that airway is controlled, make sure that the patient has the oxygen they need, and transport the patient, especially because the condition may continue to worsen. So this might sound like something out of a movie, but I want you to be aware of it. This is what we call detergent suicides. And it's a method of suicide that began in Japan, and we see it now in the United States. But what the individual does is they have two chemicals. They mix those chemicals knowing that the two chemicals together produce hydrogen sulfide gas. So hydrogen sulfide gas is going to kill you. It's a poisoning. And these people will do this in their car or in a smaller enclosed space so that the gas is more concentrated and doesn't escape. In some cases, the individual may be trying to harm themselves, and they think about the fact that someone's going to find them. They may leave a note on the vehicle, on the window, that says, "Do not open, poisonous gas," or anything like that. We need to be alert for that. But understand, if we've got someone who appears to be unresponsive in a vehicle, look inside that vehicle before you open the door and see if you can identify anything that tells you not to open the door. You may need to be treated if you are exposed. And if we identify this is a potential chemical gas that's inside this enclosed space, the hazmat team is likely going to be called. Absorbed poisons are poisons that can be absorbed through the skin. Understand that they may or may not actually cause physical damage to the skin. So some may create a burn of sorts or a rash on the area where the patient's been exposed. Some will not have any physical evidence on their skin, but whatever that substance was can still poison them once it enters the body. Patients may require decontamination prior to treatment, and it's important that we decontaminate them before we even put them in the back of our ambulance. Someone who has exposure to some absorbed chemical or poison, again, needs to be decontaminated before putting them in the back of the ambulance. Now, we want to treat any immediate life threats as quickly as possible, but we also do not want to be spreading the contaminated substance. So we want to brush off any powder and then irrigate the skin with clean water for at least 20 minutes and throughout our transport if we can. If it's not a powder, if it's a liquid, then we are going to stick with constant irrigation. Transport with all the containers, bottles, SDS forms, labels, whatever we can gather regarding the substance, and we want to continue to reassess the patient. If the patient is complaining that they still feel irritation or burning or pain, please continue to irrigate the area so that we are trying to essentially remove any residual poison that might be on the skin. The list for injected poisons is pretty short here. Usually, we're talking about illicit drugs. We're talking about people who are using needles to shoot up. But we might also be talking about venom from snakes or insects, because that is getting through the skin through a puncture, and that is a true injected poison exposure. Poison control is a real thing. There are people sitting waiting to answer your call at all hours of the night, just like our 911 dispatchers, but they are an excellent resource. They are going to have all of the most up-to-date information on the different chemicals, poisonings, signs and symptoms you should be watching for, and treatments to help this patient. Follow your local protocols and make sure that you notify medical control as well, as far as what's going on and what you're bringing into their ER. Alcohol and drug use is relatively common, and many patients may have underlying issues that the alcohol or substance abuse has actually caused, directly or indirectly. Abuse of alcohol and other drugs is not limited to any one area. This is something that we see in our area, and you're going to find around the world. So it's important when we talk about alcohol abuse that we understand that we are not the judge. Do not be judgmental. We are here to treat the patient, and we need to do this professionally. Alcohol does affect the central nervous system, which is why you have delayed reflexes and may not feel pain sensation the same way. But because of this, we need to make sure that the patient is safe and do our best to care for them. When it comes to alcohol abuse, we may be talking about a one-nighter where they just went and binged, or we may be talking about someone who has consumed regular amounts of alcohol over years. Consumption of alcohol can cause medical conditions, but it can also cause conditions that were already there to worsen. Alcohol to many seems safe, seems, that it's not dangerous because it is a legal substance. However, alcohol can sometimes lead to other drug use. And in the instance where we have a critical patient, it's likely that there may be other substances besides alcohol that have been ingested or injected or inhaled. Impaired patients can be irrational, they can be aggressive, They can be just downright hostile and difficult to deal with. So we have to remain professional. We have to continue to do our job to the best that we can in a safe manner. And if law enforcement is needed because of concerns for our safety, then let's call them. Don't get tunnel vision if you feel someone is intoxicated and think that that's the only thing that's going on, because everyone gets a full assessment. Everyone gets the primary assessment, and if everything checks out okay, we do a secondary assessment on everyone. It's important to get a history on everyone, and that's because there are medical conditions that can mimic alcohol intoxication. Some people may act goofy or may slur their words, and it's not because they're intoxicated. They may be having a stroke. Intoxicated patients may also have underlying medical problems that again can worsen. Things like diabetes and hypertension can worsen with alcohol consumption, and we need to make sure that we're managing all aspects of this patient. So checking a blood sugar would be important. All patients are going to get the same non-judgmental care. So most often we're going to see a patient who is unsteady on their feet, uncoordinated. Maybe you can smell the alcohol on them or on their clothing. Look around the environment. Do we see beer cans or bottles? How is the patient's speech? Are they slurred? Are they rambling? Are they incomprehensible? Their skin may appear flushed. They may be nauseous and vomiting, and they may have that slowed reaction time, which means they are a risk to hurt themselves. The more alcohol that's consumed, and again, those underlying conditions, we may also see blurred vision, confusion. The patient may have hallucinations, meaning they see or hear things that are not really there. They may black out or have a lack of memory. Even though their eyes might be open, they're not going to remember any of this. And that's a scary situation. If the patient has consumed enough alcohol, again, they may pass out completely, that altered mental status, unconsciousness. It's important to remember alcohol is not something that you should just stop if you have been a chronic alcohol abuser. Stopping alcohol can be very dangerous if the body has become tolerant and adjusted to it. It's craving that alcohol. And by abrupt cessation of drinking, you can have the patient develop DTs, or delirium tremens. If a patient is trying to withdraw from alcohol on their own, we may be called because these DTs can be very difficult to work through. The patient is, again, hallucinating. They may be sweating bullets and diaphoretic, trembling, and it's very uncomfortable or painful even for the patient to sustain this. So these can lead to seizures and again need to be managed in a healthcare setting. So again, some of those signs and symptoms that you're likely to see with the patient who has withdrawn from alcohol include some confusion, restlessness, unusual behaviors with hallucinations. They may have tremors of the hands, profuse sweating, diaphoresis. They may have high blood pressure, a fast heart rate, and seizure activity. These patients, because of their confusion, may have issues maintaining their airway, or they may develop some respiratory issues. If they're vomiting, make sure that you have on your PPE, but have suction available to help maintain that open airway. Assess them for any trauma. I want you to understand that doing a full head to toe is important here, again, because they don't have normal nervous system sensation. and be alert for any changes. Even subtle changes should be identified. So of course, one way of doing that is monitoring their vital signs regularly. We can begin to treat them for shock, protect the patient from any self-injury, maintaining their airway. Look for seizure activity. If there's seizure activity, again, we need to alert the emergency department to the new issues we are experiencing with our patient and transport them quickly. So substance abuse is any chemical or substance that was taken for other than the expected therapeutic reason or the medical reason. So this can still be a legal substance, but if it's not prescribed to you or if it's not your medication, then it's technically substance abuse. This can include opiates, uppers, downers, hallucinogens, and some other volatile chemicals. Opiates are one of the substances that we may encounter. This medication is prescribed for pain or for relaxation. Now, some of these medications are prescription and legal with a prescription. However, others are illegal. So opiates include codeine, OxyContin, Percocet, Vicodin or hydrocodone, and heroin. So you have to look at opiates as being slow motion. So we get a slow pulse rate, we get slower breathing, we get low skin temperature, relaxed muscles. They sweat profusely. Their skin is just very moist. Pinpoint pupils because they're not really focusing on anything. They may be sleepy or they may even be in a coma. Uppers are actually stimulants that affect the nervous system. Uppers, again, can be legal prescription medications or illegal drugs. Uppers include cocaine, methamphetamine, your Adderall or Ritalin, those Vyvanse, those types of medications that are used for ADHD. These medications may be ingested, they may be inhaled, they may be injected, they may be snorted. It's absorbing it through the mucous membranes that you will see some of these individuals take it as. Okay, when you think about an upper, signs and symptoms of uppers are going to speed things up. We're talking about activity. They're restless, they're excited, their heart rate and breathing goes up. The individual may have rapid speech to the point we may not be able to understand them well. They may have a dry mouth and dilated pupils. Dilated because we're trying to focus on everything, we're taking everything in. These patients also can have moist skin and they're just go, 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 so they don't need any sleep. On the flip side of that, we have downers. Again, these things affect the nervous system. So the central nervous system is going to be depressed. These are things like benzodiazepines, medications that patients use for seizures, Rufinol or Roofies. This is the drug, and GHB. These drugs are the date rape drugs people can give to individuals to try to take advantage of them. So again, some are legal, some are illegal. Signs and symptoms of a downer: sluggish, poor coordination, decreased pulse and respirations, again, very slow to respond. Hallucinogens, if you think about hallucinate, that's what this is going to do. It's going to distort their perception, so they don't know if it's real or not real. They have intense states of excitement. Hallucinogens can make people do things that we think is, not humanly possible. LSD, PCP, and ecstasy are some of the drugs that you may have heard of that fall into the hallucinogens category. With this, the patients are going many times. Again, they've got increased strength and ability to do things. They have a rapid pulse, dilated pupils, flushed face, and again, reality is not always what they see it as, and so with things being distorted, they may hear or see things that aren't there. Volatile chemicals are vapors or chemicals that are put into the air and inhaled. This creates a rush and it affects the nervous system and kind of suppresses things. This is what we call huffing. Signs and symptoms: dazed, loss of coordination, loss of contact with reality. They may even develop unresponsiveness or go into coma. These vapors are usually inhaled through the mouth and nose, and because of that contact with the chemical, you may see irritation or swelling of the mucous membranes. The patient may complain of feeling tingly or numb, and there can be irregularities in their heart rhythm. What you see in this image is one way that people will huff. They will put the chemical in a brown paper bag and then just seal that bag around their mouth and nose and breathe it in so they can get their high. These volatile vapors, they can create a variety of symptoms and they affect different people differently. So your signs and symptoms may vary and it may be hard to truly identify what's going on with this individual. So make sure you look around the environment. Many times these patients that are inhaling vapors are using other drugs as well. So we need to make sure that we are assessing the whole situation, the whole patient, and be sure that you're doing your thorough assessment. Begin by asking the patient if they have taken any medications and then ask about drug use. Patients may be shaky or anxious. They may feel nauseated, confused. Sometimes they're irritable. Maybe they don't want to answer your questions or they don't want to go with you. They've got an increased pulse and breathing. They may again be hallucinating or seeing and hearing things that are not there. So again, from the top with our assessment, we begin with that primary assessment and our ABCs. Any problems with the airway or breathing or circulation, we stop and fix. Provide the patient some oxygen, assist ventilations if needed. If these patients are in a coma or unresponsive type state, we may have to breathe for them, even though we don't have to do chest compressions. If we're uncertain of the drug that the patient has taken, or if we know the patient has taken an opiate, then we can give naloxone or Narcan, and this is given intranasally. Treat the patient for shock. Try to keep them calm and relaxed. Provide reassurance. Talk to them in a gentle manner. The more aggressive you get, it's likely they will become more aggressive, so try not to raise your voice. And again, we're not judgmental. We are going to treat everybody. Don't forget, we are going to do a head to toe as part of our secondary assessment. So as you're looking at the patient's skin, look for any evidence of injection sites or track marks. Protect the patient from injuring themselves. We want to transport them as soon as possible, but remember, we want to try to do this in a calm manner. We can consult medical control. We can involve law enforcement if we need to, but always try to reassure the patient that you are not the ones that are going to be putting them in jail. You are not the ones that are going to be prosecuting them. We just want them to make it. We want them to survive. Continue and reassure your patient throughout your time with them. This image shows you the track marks of someone who has been injecting drugs. You can see how it has caused that scarring and irritation to the vessel all the way up. With poisonings, don't forget we are taking care of the patient and their ABCs first. Do your secondary assessment. Really try to find out what the poison is that you're dealing with, how the patient was exposed to it. We want to know how much they were exposed to, how long was that exposure, or how long ago was that exposure, what interventions have they done, and how is the patient feeling. Medical control can assist with identifying how to care for the patient with the particular substance. They can direct you to provide activated charcoal or for dilution with water or milk. Be sure that if this is an inhaled exposure, we want the environment to be safe for us as well. So we need to be sure that we are in a well-ventilated open area and provide extra oxygen to our patient. If the patient has been exposed topically to a poison of some kind, if it is a liquid, we flush and flush and flush with lots of water. If it is a dry substance, we want to brush as much of it off as we can and then flush and flush and flush. Don't forget to bring the container, bottle, label, or whatever it is with you that the exposure was to, so that we can get all of the ingredients and poison control can be provided with that information. Continue to assess your patient en route and reassure them. Once the call is done, it's important to make sure that your documentation is factual. Remember, working with humans is a fluid experience, meaning we don't always know what's going to come next and things can always be changing. And that's going to be especially true with your patients that have had an exposure or have substance abuse. Poisonings are generally classified by route of exposure. We understand that there are different rates of absorption and how they're going to affect the body. So we want to identify that if we can. We have to look at the environment that we're in. We need to make sure that it's safe, but the environment may also provide us with some information as far as what's going on, what the exposure has been, what the medications are that have been consumed, or the drug paraphernalia we see. It can give us some of that information that we're looking for. Poison control centers have all the answers, and again, with technology and computers, they can punch it into the computer and get all the information in a matter of seconds to help us care for this patient. Alcohol can be chronic or situational. Many times patients have underlying issues, and these can be worsened with alcohol consumption. So substance abuse can vary based on the type of substance, the type of drug. Understand that we have drugs out there that are cut or laced with other drugs, so an individual may not even be aware of everything that they've just ingested or smoked or shot into their vein. So we want to look around the environment and help identify any information if we can, but don't be surprised if more than what you thought comes back from that tox screen. So here are your questions to consider. What are potential risks to the responder on a poisoning or overdose? Well, you need to be aware of your surroundings and you need to watch out for your safety. These situations change very quickly, and a patient may be sitting, calmly speaking to you, answering questions, and become very agitated and physically violent in a matter of moments. It's important that you have the resources that you need and that you are handling the situation or escaping from an unsafe place. What are the routes of entry into the body? These are the same as medications. So inhalation, injection, absorption through the skin or mucous membranes, and ingestion, swallowing. What are some things EMS can do to prevent poisonings, especially in children? Prevention is key, and we're never going to be out of work in EMS, but trying to educate people and keep everyone safe is one of our jobs. Poisoning, especially with smaller children around, is a risk, and we want parents, caregivers, grandparents, whomever, to be aware of those risks. Putting a lock on the cabinets, educating them about child-proofing their home with the normal chemicals that they may use every day, and to them don't mean much, but to a child may be very deadly. So you get dispatched to a farm, and we've got a farmer who had one of his farm hands try to clean up a spill of some pesticide powder. So now this individual has the pesticide powder on their hands. When we get there, we find that the patient insists that he has brushed all the powder off, he feels fine, he does not want to go to the hospital. What are we going to do with him? And then as we're talking with him, he continues to make brushing motions at his jeans, and you can see the white marks of a powdery residue still on his jeans. How are we going to manage the situation now? I understand that the patient states they feel fine, but signs and symptoms may not appear for a little while. This has to be absorbed in the skin and metabolized before we're going to see the effects. The patient should still go to the hospital to be evaluated, but we do not want them in our ambulance with these jeans on. Part of decontamination is removing clothing if it has the contaminant on it, which means the individual needs to take his jeans off before climbing into the ambulance. We want to rid them of as much of that chemical as possible. We do not want to create an unsafe environment for us. Be sure that you let the emergency department know what you're coming in with and the pesticide that the patient was exposed to. See you in the next chapter.